Today we're going to be talking about lifespan disorders. Now, what are these? They're just disorders that maybe start as a kid and go for the rest of your life. And there's certain things that are sort of more unique and happen more as a person is growing up than other things. And we're going to look at those. And some of them may be pretty general, but there are several here that are very important that we're going to go more in depth on because you're going to see a lot more of them in your counseling. The first thing is mental retardation. It can be mild, moderate, severe, profound. Down syndrome as an example. How much difficulty does this Down syndrome child have? Just tremendous. And of course we know it's a chromosomal disorder, so it's not anything that is preventable at this time. It isn't anything that you can do very much about except help the person learn how to function better as they go along. It's like 1 in 800 under 35, 1 in 100 over 35. That's the age of the mother. Distinct appearance, IQ is between about 35 and 55. That's why it's so devastating. There's another one called Fragile X syndrome. Moderate to severe mental, language, and sometimes behavioral handicap. PKU is a metabolic disorder. If it is caught, it can be dealt with by diet, but it has to be caught very early within the first 3 months for it to be treated. Sachs disease, excessive accumulation of fats. Fetal alcohol syndrome. This if the mom was drinking alcohol excessively, the child just has a particular look and it causes major problems. Birth-related causes. Too little iodine, creatism, syphilis, lead poisoning, anoxia, extreme prematurity. All of those things can affect the kid, and you're going to see some of those things maybe in your counseling. But most of these are going to be dealt with what? By doctors, by physical things, by whole programs. They don't usually come to a counselor with someone that has, say, Down syndrome, and you're going to be counseling them unless you specialize in that particular area. Learning disorders. Dyslexia. That's where the letters seem to be switched, so they have a hard time reading that. There's a mathematics disorder. Disorder of written expression. Learning disorders not otherwise specified. Now, why do you want to know that? Because sometimes you're going to have other things. Like I had a client that was just very angry. And we finally figured out that the whole thing was a learning disorder. It started in the 3rd grade, and the kid felt so bad that he couldn't learn that he became oppositional to cover up the learning disability that he had. He refused to take the test, refused to do the homework, and so on, because that way no one would know that he had a learning disorder. Motor skill disorder, slow movement, or bad motor coordination. Communication disorder. Expressive language disorder. They have a small vocabulary and trouble producing sentences. Mixed receptive expressive language disorder. A hard time expressing or understanding. Then we have pervasive development disorders. And the one that you probably know the most about or you've seen is autism. We still don't understand exactly why this happens. There have been all sorts of theories and ideas, but we just don't understand. But anyway, the outcome is poor social interaction, communication, and stereotype behaviors and interests. React to their environment in bizarre ways. Symptoms appear before age 3. 2/3 can't lead independent lives in adulthood. They react badly to change. They self-stimulate or injurious behavior. Many times you'll see them with helmets on, or they'll put them in padded rooms. Where you see most of this is in the schools, because the schools have a mandate that they have to deal with kids that have all of these types of problems, and they usually put them in special classes with a lot of teachers' assistants and so on to try to help control them and get whatever help they can. And they have some very interesting things these days, like with computers, that the kids that can't really speak can actually punch in computers and actually talk and communicate that way. So there is some progress, but it again is a very physical type of a thing, but you might see it in counseling to a certain degree. Inability to comprehend sound stimulus, over-selectivity, possibly genetic factor, possibly caused by prenatal difficulties, maybe multiple biological causes, parent interactions with the child maybe, but probably more physical. Treatment, teach them how to adapt better to their environment. Sometimes the drugs can help a little bit. Stop self-injurious behavior. Teach them to communicate. Only about 50% are able to speak. Rett's disorder, slow head movement, delayed language, poorly coordinated gait, loss of purposeful hand movement, or social engagement. The idea here, though, as a counselor, you might get somebody coming in because of certain problems, and if you don't know these things exist, you might not identify and say, well, I think we better send you a doctor, but it looks like this is what we're dealing with. Childhood disintegrative disorder. After 2 years of normal development, the child starts losing the skills. Asperger's disorder. It's similar to autism, but the language is okay. And then, of course, we have pervasive development disorders not otherwise specified. Now, one that you're probably going to see a lot of that we're going to talk more about is attention deficit hyperactivity disorder. Now, in the past, this was broken between ADD and ADHD. It's no longer that way. It's all ADHD broken into 3 particular areas. And the first part of the criteria in these areas is inattention. Either inattentive and or hyperactivity impulsivity for 6 months that is maladaptive and immature is shown by 6 of the following. Fails to pay close attention to details or makes careless errors in schoolwork, work, or other activities. Has trouble keeping attention on tasks, even in play. Doesn't appear to listen when being told something. Neither follows through on instructions nor completes chores, homeworks, or jobs. Has trouble organizing activities or tasks. Dislikes or avoid tasks that involve substantial mental effort, like homework or schoolwork. Loses materials needed for activities. Easily distracted by external stimuli. Is forgetful. Okay, that is if it's the inattentive type, and you can have a combination of these. If it's the hyperactivity type, squirms in seat or fidgets. Inappropriate leaves seat, runs, and climbs. Has trouble quietly playing or engaging in leisure activity. Appears driven or on the go, talks excessively. When you see a person like this, say a kid comes in that has this, and by the way, this can go on into adulthood, but many times through growth it will sort of disappear as they get older. But the kid will just be all over the place doing stuff, and you can't get them to sit down for very long, and you can't get them to really pay much attention or answer questions or do things like that. Then we have impulsivity. Answers questions before they can be completed. Has trouble waiting for their turn. Interrupts or intrudes on others. Some of the symptoms began before age 7. Present in at least 2 types of situation. Impairs school, social, or occupation. Where do you think you're going to get kids? What are the complaints going to come from? The parents or the schools is what you're going to see. Because the teachers are going to really have a problem with these kids in their schools. Now, what's the most usual treatment? Yeah, medication. But you're also going to get kids that don't respond to medication. Now, here's sort of a picture of this to try to understand this from the kid's point of view and why you get the kind of stuff that you get. because you also get a lot of oppositional behavior and a lot of other acting out and other problems and fighting and other stuff in the schools that goes along with this. But the best way to look at this is it's an unfocused brain. Think of yourself, if you wear glasses, how well do you do in a room interpreting things correctly if you don't have your glasses on? And how much effort does it take to really read something? See, many times these kids get a very bad rap because they can do certain things. You'll notice they can play video games very well. You notice that they can, if they really work hard at it, read. And they can do all these things. But what if you had to read everything for this class without your glasses? How would that affect you? You'd be squinting all the time. See, when you try real hard, they can think. When they try real hard, they can control their impulses. When they try real hard, they can control their fidgeting. But can they do that all the time? And so, but how do they see things? That's the way they are. That is their capabilities, right? So for them, everyone's always down on them. Everyone is always critical. Life is not fair. Because they're doing their very best and everybody says they're messing up. And they don't know what they're messing up. Because they have no other way of seeing it. They've never had good vision. And because of that, they feel everyone is against them. And how do they react? And they feel everyone's critical. They're never going to be good enough. They can't measure up to the other kids. So they get in all sorts of fights. They get in all sorts of problems. Their parents don't think they obey them. They forget things. You know, how can you be so forgetful? Well, if you couldn't see, do you think you might forget a few things in the room too? And so it's one of these snowballs that it starts out with these symptoms, but then because how the kid reacts to those symptoms, you're going to have all sorts of reaction. One kid that I was treating for ADHD was getting kicked out of everything. I mean, he was kicked out of school like 2-3 times a week. He was kicked out of sports. He was kicked out of everything because he was so fidgety and had such a hard time controlling, he just run off the field. Was the coach going to have a kid just run off the field? Or is the teacher going to put up with this for very long? Or what are the other kids going to do? It turned out that a lot of the other kids were playing him for a sucker. They would mess with him when the teacher wasn't looking, and of course when he did something back, he got in trouble. So do you see the problem? So what are you going to do? What's going on here? Predominantly, they have all three of these, not just one. 50% also have learning and communication problems. 80% misbehave, but you understand how I just explained what the misbehavior really is. 1/3 continue into adulthood. Relatives are more likely affected. So if you have somebody, ask them, do your parents have this? Because it seems to have a sort of a genetic thing here. Etiology unknown, but theories include minimal brain damage, stress, multiple or interactive causes. Treatment, primarily Ritalin. There's particular diets that sometimes can help. The idea that sometimes colors can have an effect. Haven't seen that really help that much. Teaching parents and teachers how to systematically reinforce the attention and the behavior. So basically what it comes down to is behavior modification. If we have very solid rules, very clear lines, they can learn how to do better in each of these situations. One of the things I was doing with one particular kid, and see, don't think these kids are necessarily dumb. I was playing this kid chess. And what I was showing him in the chess is when he calmed down and slowed down and thought about his moves, he won. And when he didn't, he lost. And when he would come in very hyper, he never could win a game. But he was actually good enough, he could beat me sometimes if he was calmed down. But I was using that as an illustration of life. Now, if you can win chess that way by calming yourself down, what are you doing to control yourself when we're playing chess? Of course, he was focusing. So can you now focus at school? Can you now play the chess game at school and don't let these other kids suck you in and get you in trouble for stuff they're doing to you? See the idea? Another one that is really critical falls under, actually several of them fall under this, called disruptive behavior disorders. In a way, the ADHD, remember 80% were disruptive? So you're going to have to sort these people out, aren't you? Which ones is it primarily ADHD? Which ones are primarily... The first one is conduct disorder. And this is the one that many times you start with reaction attachment disorder. It goes on to conduct disorder and moves on to antisocial personality disorder. Violates rules and the rights of others. For 12 months or more, the patient has repeatedly violated rules, age-appropriate social norms, or the rights of others. This is shown by 3 or more of the following, at least one of which occurred in the last 6 months. Aggression against people, bullying, starting fights, uses a weapon that could cause serious injury. Now, these are kids. Physical cruelty to people, physical cruelty to animals, theft with confrontation, like armed robbery, something like that, forced sex upon somebody, property destruction, deliberately sets fires or destroys property, lying or theft, broken into buildings, car, or house, frequently lies or breaks promises. Basically, they're conning. Stolen valuables, burglary, forgery, shoplifting. Serious rules violation. Before age 13, stays out all night against parents' wishes, runs away twice. Before age 13, truancy. These are clinically important, and if over 18, does not meet the antisocial personality disorder criteria. So what's this kid like? This is the kid that everyone just can't control, that they're going out there hours doing things to violate and hurt other people. Then we have oppositional defiant disorder. For at least 6 months, the patient shows defiant, hostile, negative behavior. 4 or more of the following apply. They lose their temper, arguing with adults, actively defy or refusing to carry out rules or requests of adults, deliberately doing things that annoy others, blame others for their own mistakes or misbehavior, being touchy or easily annoyed by others, being angry or resentful, being spiteful or vindictive. Again, clinically significant and not from something else. Now, can you see that a person acting like this and the things they may be doing could be easily confused with the person that has the conduct disorder and some of the same things you would see with the person with ADHD, right? So do you see, you're going to have to really sort those out and go to the criteria to sort out which ones we're actually dealing with. Then we have disruptive disorder and not otherwise specified. What's going on here? Rejection, abandonment, failure to provide consistent discipline and supervision, all sorts of things growing up. Treatment is more effective if you can get them before age 13. Teach parents more effective ways to deal with the behavior. Obviously, how about boundaries? How about rules? See, what are some of the things that we use here a lot? We'll start out with family rules. If they don't work, we'll go to love and logic, which basically is you just let them learn the hard way the consequences of what they're doing. The next step up from that, though, is we will make them perform for what they get. As an example, let's say the kid's being very oppositional or doing some of these kind of things. You basically say, okay, I'm locking up all the cords to all the TVs, to all the phones, to all the computers, to all the video games in the house. They're in the trunk of the car. After you do this, 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 and this, you take care of this, you do okay. If you blow this, you simply don't get any of the pleasures that you want. So it makes the parent now totally in control. But there's a step even beyond that. And this is used like when we had charter here. When the kid arrived, they basically got a room with a mattress. And until they wrote their life story, they didn't get any privileges whatsoever. And we've had to do that before in these situations. A family came home one day and their daughter was there, had her whole gang of friends there tearing up the house, found out she was on drugs and having sex with everybody and so on and so forth. After she went to treatment, when she came back, we had to set up this kind of a thing. You know, you've lost the trust of your parents, so therefore you get nothing until you earn it. Every little piece. You don't get a phone, you don't get anything until you earn it, until you get your grades back together, until you do this, until you do this, until you do this. And so sometimes you have to apply that much external control to get this under control, and then teach them skills and help them to be able to do these kind of things. There are a bunch of other very interesting ones here that will sort of blow your mind a little bit, but we'll look at them. Feeding and eating disorder in infancy or early childhood. Pica, eating which is not food. Just whatever there is, they pick off the floor and try to eat it. Rumination disorder. Regurgitating and chewing the food already eaten. Feeding disorder of infancy and early childhood. They eat too little or they eat too much, gain too much weight, too little weight. Tic disorders. You've probably heard of Tourette's disorder. Multiple vocal or motor tics. It can be cussing, it can be all sorts of stuff that is going on in this person. Chronic motor or vocal tic disorder. Transient tic disorder. Tic disorder not otherwise specified. We're talking about tics, little movements like that. You know, you're not thinking it's going on and what's happening. And then elimination disorders. A person who just can't control their bowel movements. Or bedwetting as the kid gets older. 7% of boys, 3% of girls. Usually inner conflict, disrupted family, poor toilet training. Treatment, classical conditioning, an approach with a bell, some help from drugs, but the help usually drops out when you drop off the drug. So mostly it's behavior modification that you're using here. Other disorders of infancy, childhood, or adolescence. Separation anxiety disorder. Anxious when separated from parents. What are you going to do about that? Systematic desensitization. Slowly get them a little bit away from the mom and so on and so forth. One particular kid that had this and the mom couldn't do anything, what we had the mom do is get one of those playpens. And so the mom would go into a room, bring the kid with her, put the kid in the playpen so the kid could be near her and see her, and then she could get some work done. And then slowly, of course, move it farther and farther away. Selective mutism, elects not to talk. Reactive attachment disorder, we've talked about that, and that is when the kid doesn't bond. And many times if you're adopting kids from overseas and places that are really in bad situation, they'll have this. But sometimes the mom was just sick, and they never bonded. Bonding therapy is used before age 11, but you have to be careful because there are all sorts of when people got sued and so on because they overdid it and the kid died. I had some instructors in counseling that had adopted a child from Bolivia. And when the child arrived, the child couldn't even walk. He would just scoot around the floor, picking up all the stuff off the floor to eat it. And had severe RAD, and they spent a year doing bonding with this kid. Just hold it. The kid would scream and yell and everything else as they would hold the kid close, sometimes for 8 hours a day, until the kid would be so exhausted the kid could do nothing but be close to them and bond. And eventually they got it turned around that way. But after a kid is older, like if you don't see the kid till after age 11 and so on, then the bonding thing is probably going to be a lot harder. Because they're going to feel what? No one cares for me. No one is going to take care of me. I have to take care of myself. And you're probably going to see that, as I said, attached to the conduct disorder, the oppositional defiant disorder, other things like that. Stereotypic movement disorder. Bangs the head, bites self, pricks skin. Disorder of infancy, childhood, or adolescence not otherwise specified. Then we have, in DSM-4, other factors that need clinical attention. Remember I told you before there's an awful lot of stuff that's not really covered as mental disorders, but they're major things that you are going to see in counseling? Psychological factor affecting mental conditions. Those refusal to do what's necessary or to improve. Neuroleptic induced problems. But then the relationship problems are the V codes. And I'll just run through these rapidly, but you're going to see there's an awful lot of stuff there that to explain what you're really dealing with, you're going to have to put V codes in. And the V codes are what really explain what's going on. And these V codes all have numbers. And so you actually put the number in for them. Relationship problem related to mental disorder or general medical condition. How many people do you think might have that? Parent-child relationship problem. Partner relationship problem. Sibling relationship problem. Relationship problem not otherwise specified. Physical abuse of child. Sexual abuse of child. Neglect of child. Physical abuse of adult. Sexual abuse of adult. Non-compliance with treatment. Malingering. Adult antisocial behavior. Childhood or adolescent antisocial behavior. Borderline intellectual functioning. Age-related cognitive decline. Bereavement. Academic problem. Occupational problem. Identity problem. Religious or spiritual problem. Acculturation problem. Phase of life problem. Does that cover about everything? But see, you use those V codes, they're not an actual mental disorder, to explain more of the mental disorders and the things that you're actually taking care of on the other axis. So let's sort of put this all together now, because next time we're going to get into this and actually really try to look at some of the critical things of how you actually do diagnosis, or in this case we're calling assessment, since you're not licensed to actually do a diagnosis. Remember, first we have the axes, right? And axis 1 was what? Those critical, acute type of things that aren't lifelong. Now, they could end up being lifelong, but they aren't necessarily lifelong. They're not personality disorders, right? Then in the second axis, we had the personality disorders, or also mental retardation. Goes on axis 2 because it's a lifelong type of thing, right? Then on the third axis we have medical problems. Then on the fourth axis we have social problems, like what's going on in the family or whatever, and you just put in whatever the social problems are that are going on. And then on the fifth axis is the GAF, the General Assessment of Functioning. And that's a number that you put down basically in how well this person overall is functioning. And the higher the number, the more they're functioning adequately, and the lower number, the least they're functioning adequately. So how would you do this? How would you figure out what a diagnosis is? Well, obviously, the first thing you have to do is get to know the client and ask them a bunch of questions, right? And gather the information, and then eventually figure out what category you're looking at. And by the way, in the back of your DSM-4, the actual book itself, not DSM-4 Made Easy, they do have flow diagrams that will help you in very complicated ones, like for psychosis or for mood disorders and so on. And you can go through a flow diagram eliminating certain things so you make sure you end up of where you should end up. But the challenge of the whole thing is translating from that real story into what is a diagnosis that you would give them on all 5 of these axes. And that's what we're going to be talking about next week. Let's pray. Lord, we thank you that you have the answers. And Lord, that you care for us and you care for everybody. And Lord, that you'll help us to learn how to sort these things out and how to get people the help that they need. In Jesus' name.